Today I'm going to tell you about malaria. What is this disease and why is this disease so deadly? Bill Gates once correctly pointed out that there are more people dying of malaria than any specific cancer. Transmitted in more than 87 countries worldwide, the disease has especially been creating havoc in African and other tropical countries. It has caused millions of deaths each year. The disease is caused due to protozoa called Plasmodium. The notorious species causing the infection are Plasmodium vivax, falciparum, malariae, ovale, and knowlesi, which is the monkey parasite of Southeast Asia. Occasionally, humans have also been infected by the monkey parasites Plasmodium simium and cynomolgi. Now let us see what causes the spread of the disease. The disease is transmitted by the bite of a mosquito called Anopheles, which acts as a cyclopropagative vector. That means the Plasmodium undergoes sexual reproduction as well as multiplication in this vector. Anopheles is small and dark with long palps and scales on the wings. Now let us see what happens when an infected female mosquito bites a human host. The mosquito inoculates Plasmodium sporozoite from its salivary glands into the human. This sporozoite rapidly reaches the liver and invades liver cells by binding to hepatocyte receptor for serum proteins thrombospondin and properdin. And with this begins the exoerythrocytic cycle. Within the liver cells, malarial parasite multiplies, releasing as many as 30,000 merozoites and thereby rupturing the liver cell. Now there is one interesting thing that we need to know about Plasmodium vivax and ovale. Here, some latent hypnozoites remain in the hepatocyte, and these are responsible for the later relapses that we can see even after several weeks or months of the primary infection. Once released from the liver, the merozoites bind to the sialic acid residues on glycophorin molecule on red blood cells and invade it by active membrane penetration. Plasmodium vivax uses the Duffy blood group antigen to enter into the red blood cell. Now inside the red blood cell begins the erythrocytic cycle, and the parasite grows by hydrolyzing hemoglobin and passing through several stages. The first one that you can see here is the ring form, and then comes the trophozoite form. And after that comes the multinucleated scission stage, which ruptures and releases more merozoites into the bloodstream. These erythrocytic stage can sometimes persist for a long time even after the primary attack, especially in case of Plasmodium malariae and falciparum, and that gives rise to the recrudescence. That means a repeated attack of malaria due to survival of malarial parasite in the RBCs. Now let us take a quick peek into the Giemsa stain blood picture of these parasites. The thin smear is useful for identifying the malaria species and identifying the percentage of red blood cell infected. This is the blood picture in case of falciparum infection, which infects red blood cells of any age. Multiple infection in the single red blood cell can be seen here. First comes the ring stage. After that, you can see here is the trophozoite stage, and after that is the scission stage. The falciparum, trophozoite and scissions are rarely seen in the peripheral smear because they are sequestrated in the capillaries. Lastly that you can see is the gametocyte of Plasmodium falciparum. It has a characteristic banana or crescent shape. Next comes the blood picture of vivax malaria. It has the predilection to infect young red blood cells and reticulocytes. Infected red blood cells become enlarged and distorted here, as you can see in the first ring stage. After that comes the trophozoite stage, where you can see the amoeboid cytoplasm. Then comes the scission stage, and finally the gametocyte, where you can see the gametocyte is round and oval in shape and completely fills the red blood cells. Now comes the blood picture of Plasmodium malariae. It has a predilection to infect older red blood cells. Here you can see the ring stage followed by the characteristic band-formed trophozoite or sometimes basket-formed trophozoites, followed by the scission and finally the gametocyte, which almost fills the red blood cells. Next, what you see is the blood picture of Plasmodium ovale infection. It has the predilection to infect reticulocytes. Ring form here has large chromatin dots and sturdy cytoplasm, as you can see here. Then comes the trophozoite stage and the scission stage. A dark brown pigment can be seen in the scission stage, and finally is the gametocyte, where you can see it again fills the complete red blood cell. Next, what you see is the blood picture of Plasmodium knowlesi infection. It also prefers to infect young red blood cells. The first one is the ring stage, where you can see double chromatin dots just like falciparum malaria. Rest of the blood picture is similar to Plasmodium malariae infection. Here I want to tell you a little about babesiosis, which is caused due to Babesia microti and divergens, which are malaria-like protozoans. They are transmitted by ticks and their reservoir is the mouse. It also causes fever and anemia, just like malaria. The blood picture also superficially resembles falciparum ring stage. But there are key differences that you can note. Babesia infection lacks the hemozoin pigment and it exhibits greater pleomorphism. You can also note the characteristic Maltese cross here, which are considered to be diagnostic if found. You need to know one more thing about the blood picture of falciparum and vivax infection. Maurer's dot can be seen in falciparum, while Schuffner's dots can be seen in vivax and ovale blood picture. So when these infected red blood cells rupture, they release multiple merozoites which restart the erythrocytic cycle, and thereby the rupture of RBCs causes anemia and fever. In severe malaria, the patient can become severely anemic with hemoglobin level falling even below 5 gram per deciliter. And this could happen especially in case of falciparum malaria. Now let us see inside the blood vessel and see why falciparum malaria is so deadly and dangerous. At this point, we already know that falciparum can infect red blood cells of all age groups. These infected red blood cells develop cytoadherence, that is, they stick to the endothelial lining of blood vessel, causing sequestration of RBCs inside the blood vessel. They also clump to each other, forming rosettes, and also to the uninfected red blood cells. All this stickiness causes blockage of the blood flow. The sequestration is also the reason why the parasitemia is often underestimated in case of falciparum malaria. Several proteins are implicated for causing this stickiness, but the most important protein involved is Plasmodium falciparum erythrocyte membrane protein 1. Now let us see what other complications can develop in case of severe malaria. The most important cause of death in severe malaria is usually due to involvement of the brain, which is called as cerebral malaria, and the patient presents with impairment of consciousness and seizures. In falciparum malaria, the vascular stasis as well as the local inflammatory reactions can be seen pathologically, and these are termed as Durac granulomata. In some patients, the circulatory system can also be involved, and the patient could present with shock with very low blood pressure. The lungs can be involved in the form of pulmonary edema or respiratory distress independent of the pulmonary edema. Hepatic dysfunction and cholestasis has also been seen. They all cause jaundice and tendency to bleed. Sudden and massive cola-colored urine due to hemoglobin urea can also occur because of the intravascular hemolysis. Renal impairment with serum creatinine level more than 3 mg per deciliter can also occur in severe malaria. In severe malaria, the patient can also develop prostration in which he becomes unable to sit without help. Parasite level of more than 2% in low intensity transmission areas or more than 5% in high transmission areas have also been included in severe malaria. Hyperlactatemia or the lactate level more than 5 millimole per liter can also occur in severe malaria, attributed to several factors like metabolism of intraerythrocytic Plasmodium parasites or increase in the anaerobic glycolysis in hypoxic cells and tissues as a consequence of parasite sequestration and anemia. This can lead to acidotic breathing in the patient, which you can see here in the graph as blue line. The most common biochemical abnormality in severe malaria is hypoglycemia, which is considered to be due to cytokine-induced suppression of gluconeogenesis as well as increased glucose consumption caused due to fever, parasites, and anaerobic glycolysis, which could be further aggravated by treatment with quinine. A landmark development happened in October 2021 when a vaccine was endorsed by the World Health Organization for broad use in children for protection from malaria. This was the malaria vaccine RTS-SA-S01, also called as Mosquito. There are certain other candidate vaccines which are still under development. The Mosquito vaccine uses Plasmodium falciparum circumsporozoite protein, which is fused with the hepatitis B surface antigen. The vaccine has shown around 77% efficacy rate against severe malaria. 4 doses of the vaccine are required for full protection. And at present, WHO recommends the vaccine in children 5 months and above. Now let us see some important questions regarding malaria. Morer's dots are seen in which species of Plasmodium? We already seen that it is seen in Plasmodium falciparum infection. Here you have to identify the organism related to the image. You can see there are multiple infections in single RBC, which is most commonly seen in the Plasmodium falciparum infection. What is the content of malaria vaccine? We already discussed it is the circumsporozoite protein of the Plasmodium falciparum. The next question is recrudescence are commonly seen in Plasmodium falciparum and relapses are seen in vivax and ovale infection. A 25-year-old patient presents with fever and pallor. Peripheral cells show band across the red cells. What could be the diagnosis? We already know that in Plasmodium malariae trophozoite stage, there are bands seen across the red blood cells. So the answer is Plasmodium malariae. So again, the band form of Plasmodium malariae is actually the trophozoite stage. Coming to the next question, scizones are not seen in peripheral blood of which malarial parasite? So we know that the scizones and trophozoites are usually not seen in the Plasmodium falciparum infection. What kind of transmission is seen in mosquito in case of malaria? And we have also discussed this one. The answer is cyclopropagative. The last question here is the sickle cell anemia leads to resistance towards. Sickle cell anemia actually leads to relative resistance against severe forms of malaria, which is most commonly seen in falciparum. So the answer here is P. falciparum infection. That was too much of a theory, wasn't it? But it was an important one, and I hope you found it interesting. Thank you.